All right, got it. It is top of the hour. I will welcome everyone. Thank you everybody for joining us. Dr. Del Rio, welcome. Dr. Del Rio is the Executive Dean of Emory School of Medicine and Grady Health System. He is Distinguished Professor of the Department of Medicine, Division of Infectious Disease, Emory University School of Medicine. He is also Professor of Global Health and Epidemiology at Rollins School of Public Health. He serves as co-director of the Emory CFAR and co-PI of the Emory CDC HIV Clinical Trials Unit and the Emory Vaccine and Treatment Evaluation Unit. Dr. Del Rio's research focuses on the early diagnosis, access to care, engagement in care, and compliance with antiretrovirals and the prevention of HIV infection. During the COVID pandemic, Dr. Del Rio has been a leader locally and nationally doing research, developing policies, and contributing publications to advance our understanding of COVID and advising municipal, state, and national leaders. It is a great privilege to have him join us today to present at our UCSD High Rounds, which we are jointly sponsoring today by our own CFAR Ending the Epidemic Scientific Working Group. Dr. Del Rio will present the HIV epidemic in the US. Can we end it? And take it away, Dr. Del Rio. I will give you a 10-minute warning before the end of the presentation, and I will monitor the chat and only interrupt you if questions are sort of critical to moving forward. Take it away.
Thank you, Susan, and delighted to be invited to speak to this group. Obviously, a fantastic HIV research group, and one that has had I had a lot of opportunities to interact with and to see the work done by CFAR by being as the advisor in their advisory committee and other opportunities that you guys have given me. So these are my disclosures. So I think we've seen an unprecedented breakthroughs that have occurred in HIV research in both HIV prevention and treatment that has made many feel that we now have the tools to end the HIV epidemic, even in the absence of a vaccine. And I think that's really quite remarkable, because when you think about it, we used to say, well, we're doing this until we have a vaccine, But the idea that we can do it without a vaccine, I think is pretty unique and certainly very novel. But it wouldn't be just that unique in the sense that you can think about hepatitis C and how we are using treatment, and people think that we can actually eradicate hepatitis C if we do it with treatment and without having a vaccine. So where are we in today in the United States? And this is the most recent data available. And I think the first thing you realize is that the data we have at a national level from CDC is data from several years ago. This is in fact pre-COVID data. And it just shows you that we really don't have data that we can, actionable data on a day-to-day basis that we can rely, and we have to rely on data from several years ago. So I think our data systems and data problems are one of the issues that don't necessarily allow us to do the kind of stuff that we need to do to end the epidemic. Having said that, in 2019, there were 36,700 new HIV diagnoses in the US with a rate of 13.2 per 100,000 population. And you can see in the map there are some states, for example, Montana or Idaho, where the rates are much lower, in the 1 to 2 per 100,000. And you have some states in the southern US where the rates are much higher, in fact, almost double or more. And for example, I'm in Georgia, where the rate is twice the national average. So clearly, we have not a unique epidemic in the US, but obviously a patchwork of epidemics. And the number of people living with HIV, again, about 1 million people living with HIV for a rate of 379.7 per 100,000. And that varies remarkably from some areas of the country. For example, in DC, the rate is over 2,000 per 100,000. To areas of the country, again, like Montana, where the rate is 74 per 100,000. In addition to that, as you can see, those diagnoses, 36,740 diagnoses, 66% of them occurred in men who have sex with men, and you can see their distribution of the other cases. But obviously, men who have sex with men are the main focus and the main drivers of a lot of transmission in our country. And when you see the trends between 2015 and 2019, we've seen, overall some decrease in the number of diagnoses, about 10% decrease in men, about 7% decrease in women, but we've seen a slight increase in transgender, both transgender men and transgender women between those two periods. And when you look at race ethnicity, similarly between 2015 and 2019, we've seen the rate, decreased 12% in Black African Americans and decreased 11% in Latinos, but increasing in some other groups, particularly among Native Americans and Alaskan Indians. Again, living in the Southern U.S., we emphasize that this is really where the epidemic right now is deeply rooted. We have a little bit over 50%, 51% of the new diagnoses occurred here, and the rate is higher than in most places, and a lot of it is related to social determinants of health. So when you think about what is driving the epidemic of HIV, but what is driving many other problems, diabetes, hypertension, obesity, you name it, it's really a combination of poverty, lack of health insurance, lack of access to care, lack of Medicaid expansion, lack of employment. All those things really are what's driving the HIV epidemic and many other problems in the Southern US. And you can see that here when you look at diagnosis of HIV infection among MSM in the region of residency, you can see that, it's in the South where most of the diagnoses among MSM have occurred, compared to, for example, in the Northeast, you have 1,000 MSMs diagnosed. In the West, even lower number, and you see here in the South the great, almost 6,000 of the 36,000 diagnoses occurred in MSMs who live in the South. Now, you guys are in New Mexico, in Tijuana, in San Diego, close to Tijuana, and you have done with Stephanie and her group a really remarkable work in the Mexico-U.S. border in Tijuana. Tijuana is the 5th largest city in Mexico. It is the Mexico-Tijuana border is one of the busiest border crossings in the world. There are more than 50 million crossings each year, and a combination of migration coming from Central America, South America, Mexico, trying to get to the U.S. that frequently get stuck in Tijuana. Commercial sex work and drug use are driving HIV transmission in Tijuana. And in fact, in 2021, the number of HIV cases in Baja went up over 100% compared to the prior year. And in addition to that, again, another study from Stephanie and her group shows that the HIV care continuum among some of the key populations in Tijuana, for example, injection drug users, is simply really not very good. We have a big problem with people not knowing their status, right? You can see that only about 11% knew their status. Once they know their status, they're linked with care, and then very few are receiving antiretroviral therapy. So you have a lot of people living with HIV, and compared to other places in the US where a lot of people living with HIV are actually virally suppressed, in Tijuana, most people with HIV either don't know their diagnosis, and when they know it, they're not necessarily in antiretroviral therapy and therefore not virally suppressed. Just a quick mention about deaths from people with HIV. About 15,000 people died in 2019. And again, in some regions of the country, for example, here in Georgia, HIV continues to be among the top 10 causes of death among Black men, compared to other places where that's not the case. And that again has to do with how many of them are actually virally suppressed and doing well with their HIV. So in summary, it is really Black and Hispanic men who have sex with men who are really driving the bulk of the new HIV diagnosis. 55% of new HIV diagnoses are either among African American and Hispanic men who have sex with men, and they are the most impacted, the most affected population. And in fact, in data that was seen recently shown by CDC, they talked about lifetime risk of getting HIV. When you think about when this data was first presented, CDC estimated that a Black man had a 1 Black MSM had a 50% 1 in 2 chance of being infected with HIV in their lifetime. Recent data is a little more encouraging. This was presented at CROI this past year, and basically shows, the lifetime risk of an HIV diagnosis is now 1 in 27 for Black males, and 1 in 75 for Black females. But again, when you think about Black men who have sex with men, continues to be very, very high. And in our country, while we're doing better in our HIV care continuum, the reality is we still continue to have a problem with retention and care. We're doing very well diagnosing people. We get people into care, but then people drop out of care. And in fact, when you look at this data of the people that dropped out of care, basically 80% of new infections are really coming from people, who either not diagnosed or not retaining care. And if you look at those two, the great majority are coming from people who are not, who are diagnosed but are not retaining care. So with all this data, can we really treat our way out of the epidemic? Is that something that we think it's possible? And I frequently ask myself, really, is that what we think we can do? But having said that, I think a lot of things have been written to say, yes, we can do that. And the most recent is obviously the plan to end the HIV epidemic that was revealed in 2019. So what is the ending the HIV epidemic plan? And the goal is a 75% reduction in new HIV infections in 5 years, and a 90% reduction in 10 years. And the efforts are focused on 48 counties, DC and San Juan, which account for 50% of new infections, and in 7 states with substantial burden of HIV. Many of them here in the South, for example, Alabama doesn't have South Carolina again doesn't have one of the focus counties, but it's a focus state in the eradication. And the plan basically is focused on diagnosing, on treating, increasing PrEP, responding to outbreaks, and working on improving the workforce. So where are we in some of these issues? Well, so when we think about diagnosis, is really how do we offer HIV testing, and how do we get tested those that have yet to be tested? And roughly about 159,000 people in the US remain to be diagnosed. So that's about 15% of those living with HIV. So how do we close that gap? How do we, we first of all have to prioritize HIV testing. I think opt-out HIV testing in healthcare settings continues to be a challenge. I tell people that this is the most ignored CDC recommendation. CDC long time ago recommended opt-out testing in healthcare facilities, and very few places have actually paid attention to this. I think we need to think about, adapting strategies for universal testing in some communities. How do we do, what Search Study and others have done to really go into communities and really test in a fairly significant way? I think we need to use technologies like social media, and I think we need to think about innovative service delivery strategies such as home-based testing, self-testing, mobile apps, et cetera. So this is an example of an internet distributed HIV self-test. This was a CDC-funded RCT in which MSMs were recruited through online banner announcements and randomized to control versus self-testing. And the self-testing group received 4 HIV self-tests that they could be replenished. And self-test participants reported more HIV testing, more of their social network members got tested, and more HIV diagnoses were made compared to controls. So again, this is a good example of trying to do a study, a randomized trial to test this intervention and see if it makes a difference. As far as treat, how do we link and retain patients in care? This is a study from my colleague, Jonathan Colasanti, in our clinic. And you can see, if you look at 1 month, if you look at 12 months, if you look at a year, our retention rate is 81% and our suppression rate is 83%. But when you look at that population and then you follow them over time, by the end of 3 years, you only have retained 43% of the cohort. and you have suppressed 36% of the cohort in our clinic. And the 6% you see in addition to that in the retention are actually people who are not in our clinic, but through the state database, we saw that they were retained at some other clinic, and the same thing with virologic suppression. So even if you add those two together, you still are under 50% retention at 3 months. However, if you follow them every year, if you do yearly analysis, you get a false impression. You say anytime retained, you got 84% retained and 73 virally suppressed. So when you're doing annual cutting in your clinic, you realize that, oh, we're doing really well, but it's really the long-term retention that actually is where we're losing people, and we're not doing, and we're not being very effective in keeping them in care. So together with my colleague Lisa Metch, we put together a proposal and we work with the NIDA Clinical Trials Network to do an intervention to try to retain patients in care who are not virally suppressed and who were actually not retained in care. And they tended to be people with significant substance abuse. And you can see that in the baseline, and we randomize people into treatment as usual, giving them patient navigator and giving a patient navigator plus adding contingency management. And if you see at baseline, about 10% of them were virally suppressed. And then when you started following them at the end of 6 months, we were able to get those that received contingency management and patient navigator, almost 46% of them became virally suppressed. So you were able to significantly improve viral suppression. Now, even the patients that were treatment as usual improved the viral suppression, simply because, again, you got them in the study and you have somebody working with them. But when we stop the intervention, when we stop the patient navigator and the contingency management, then we lost a lot of the impact, and they all went down to about 30%. So we're still much better than at baseline, but there was not as much of a difference between the different strategies, whether treatment as usual, patient navigator, and contingency management. Talking about the importance of just touching the patients, just having that contact with the study team, got about 30% of them virally suppressed. But what was most interesting to me is that throughout the study, we were able to keep 96% retention in the study. And if you can keep people retained, is this a good population to then use long-acting agents, right? Because you are keeping them retained. They're simply just not taking their medications. They're not virally suppressed because they're not taking their pills. Well, can we keep them retained? Because we're keeping them retained, we're keeping them in contact. Can we then get them virally suppressed with long-acting agents? And this is precisely what one of the ACTG studies is doing at present. So, moving on to PROTECT. So how do we successfully roll out PrEP? If you look at the data, PrEP has had a sort of bumpy rollout. We're not where we need to be. But if you see who's benefiting from PrEP, it's primarily white men. And we don't have the kind of PrEP use that we need to have in either women or in Black or Hispanic men, which are precisely the ones that need it the most. So in fact, PrEP may actually increase disparities in HIV in our country rather than decrease them. And you can see this is from one of my colleagues, Aaron Ziegler. He developed something called the PrEP to need ratio. And you can see in red are those places that have a lot of diagnosis and less PrEP use. So in other words, the number of PrEP users over HIV diagnosis gives you the PrEP to need ratio. And you can see that we are in an area of the country here where there's significant PrEP to need ratio as opposed to where you are in California, where that's doing much better. And if you look at more recent data, in 2018, the South was 31% of the nation's PrEP users, despite more than half of the new HIV diagnosis. So obviously, we need a lot more PrEP use in the South. The West, for example, has 20% of diagnosis and 25% of PrEP users. The Northeast has 15% of diagnosis and 27% of PrEP users. But here in the South, we have actually a reverse number, right? It's the only region of the country where the new diagnosis is actually higher than the percent of people in PrEP. And PrEP also has an issue of persistence. This is a study from one of my colleagues, David Sirota, in which he looked at people who started PrEP, young Black men who have sex with men in the South, who started PrEP and then discontinued PrEP. And you can see that you can have a variety of different reasons why people fail PrEP. It could be, biomedical failure because, they develop resistance. It could be adherence. It could be issues of PrEP discontinuation. What he called PrEP contemplation was simply refusal. And each one of those at some point in time got infected. They were offered PrEP, but they had no interest, and then they, at some point in time, you look at this cases, each one of them became positive at some point in time, despite having had the opportunity to be on PrEP, but for whatever reason, stopping taking PrEP. And you can see in this Kaplan-Meier, the survival curve of PrEP persistence. In other words, the number of people that went on to discontinue PrEP after they had been started on PrEP. And roughly, if you look at this data, basically, from starting of PrEP to first discontinuation, the 50% of people discontinue PrEP, a little bit over 100 days after they were started on PrEP. So how do we respond to outbreaks, right? With the opioid epidemic, there are concentrated clusters that we need to address, and how do we get into those clusters very rapidly and address them? And I don't need to tell this group, but obviously, the Indiana HIV outbreak was an excellent example of the kind of things that can happen. In Scott County, Indiana, which rank 92nd in our country in many health and social indicators among the counties in Indiana, because of low life expectancy, unemployment, poverty, everything that we have talked about as driving the epidemic. In January of 2015, they had 11 newly diagnosed people, and you can see how rapidly, not only HIV, but hepatitis C started being transmitted in that community. So, and how by doing this cluster analysis, it was very clear that, needle sharing and sexual contacts were the two ways in which the epidemic was being driven in this community. And similar to that, we're seeing rapid expansion of epidemics of hepatitis C in areas that have historically had low HIV rates. And you can see hepatitis C growing in areas of the country directly related to the opioid epidemic. And we will see, that increase that we're seeing, it's happening in hepatitis C, and will soon also happen in HIV. And in fact, you can see here that, the other places beyond Scott County, Indiana, where outbreaks of HIV have been found among people who inject drugs throughout the years. So what is our problem? What is the issue that is driving a lot of the transmission? And what's driving it is that, we have the tools. We have antiretroviral therapy that leads to viral suppression. And if we can sustain viral suppression, we would be doing great. But the problem is we have a huge implementation gap. And it's really that implementation gap that many of us are really very interested on looking at and figuring out how do we improve that implementation gap, where you roughly have two major challenges. We have health system challenges, but we also have biopsychosocial challenges such as mental illness, substance abuse, poverty, transportation, food insecurity, stigma, low social support, and of course, people coming in and out of jail or prison. In addition to that, let us not forget, the bureaucratic and administrative challenges that we and our patients face, the religious and cultural issues that lead to racism and stigma, the capacity of healthcare providers, both their training and expertise, the lack of Medicaid expansion in most of the affected southern states, and the lack of health system integration. So the last point on the HIV, on ending the HIV epidemic, was really dealing with workforce. And I think here the question is really, how do we get more people interested in HIV care? In 2013, there were about 8,257 HIV care providers in the US, of which 41% were in private practice, 32% of them women, and 47.5% were in Ryan White facilities, 55% of them women. And you can see their race, ethnicity, 63% were in blacks, whites, only 11% black and 11% Hispanic, and 58% met the criteria of being an HIV specialist, and 83% of them provided primary care. And this is a study out of the monitoring and the MMP, in which was published in CID. And in that study, you can see who were those HIV providers, right? I mean, infectious disease practitioners, trained physicians were about 46%. Physician assistants were about 5%, nurse practitioners about 18%, and other specialists were either, were about a third of those providing HIV care. The challenge is what is the shortage and what do we need to do to address this? So when this MMP study was done, they estimated that there was a shortage, there will be a shortage of about 500 FTEs on HIV clinicians by 2015. And again, if you move that forward now post-COVID, that number may actually be higher. And a point that I tried to make to people is, if we think about everybody undiagnosed with HIV, for example, here in Atlanta, and we found them, there was no way we can get them into care with the current system. So obviously we need to think about different approaches and different systems if we are to provide care. If we're diagnosing people and getting people back into care, how do we get them better linked to care? So I'm going to use the last a few minutes of this presentation to tell you about a study that I've been involved with other people in collaboration with Bogdan Dozic. Bogdan is in Canada at Simon Fraser University, and we had an NIH-funded R01 looking at sort of an economic modeling of how do we end the HIV epidemic and what can we do about this. And again, this was really about, I think the question here for many of us is, we've done a good job, but we have $20 billion annually invested in the HIV epidemic in the US, and yet we are not making much progress. We're really not getting more people. The number of new diagnoses is pretty much flat. And how do we then implement the interventions, and where is the best bang for the buck, and how much money do we need if we really are to end the HIV epidemic? So we selected for the study 6 cities, and these 6 cities are home to 24% of the US population of people living with HIV. And you can see what those cities are. It's Atlanta, Baltimore, LA, Miami, New York, and Seattle. And you can see what those population characteristics are, and how many people are living with HIV and the rate per 100,000 in each one of those cities, and where do they rank in the numbers in people living with HIV. And this, as a result of this grant, we've had already several publications, and you can see some of them listed here. There are others coming, but I'm going to highlight some of the results for you, but you can look at the articles further if you're interested in that. So first of all, what is in each one of those cities the funding per person living with HIV? And this is, again, looking at 2016 data when we did the study. And you can see, for example, rapidly, when you look at Medicare and Medicaid, you can see very rapidly the difference. You have, places where there's Medicaid expansion, you have, $10,000 or more per person in living with HIV dedicated to their care. In places where you don't have Medicaid expansion, for example, Florida or Georgia, you have under $4,000 per person living with HIV for their care. So obviously the big difference right away is in expansion Medicaid making a big difference. You can see all the other expenses. Here's, the money spent in Ryan-White is pretty similar across all cities. But again, if you have money for Ryan-White, for example, if you're in New York or if you're Baltimore and you have money from Medicaid expansion, then you can use your Ryan-White dollars for social services and for patient navigators. If you're, for example, us in Atlanta, you have to use your Ryan-White dollars to pay for basic services, and you cannot do anything extra with that money. And you can see, again, housing being roughly, what expending in housing in each one of those cities pretty flat. When you look at funding for HIV prevention per city resident, again, you find some significant differences. And, you go all the way from cities that are spending, $2 to $3 for HIV prevention, and you find both New York and Baltimore spending over $5 per citizen in HIV prevention. So what happens if we maintain the status quo? If the amount of money we're currently using and we continue doing what we're doing, where will we be in reaching the goals of the ending the HIV epidemics? And we will see new diagnoses decrease about 7% in 5 years and about 8% in 10 years. And again, remember, the goal of the Ending the HIV Epidemic was 75% reduction in 5 years and 90% in 10 years. So you basically have a tenfold difference where you want to be and where you actually will get if you're doing exactly what you've been doing. But furthermore, if you continue doing what you're doing, and I told you, for example, how PrEP will increase disparities. In fact, disparities and new diagnoses will actually be exacerbated. And you will see significant disparities in multiple cities as a result of this. So then we said, well, what can we do to improve this? What are the strategies that we can implement in order not to have the status quo? And we looked at about 23,000 unique combinations of interventions per city to identify the optimal combination of interventions in each city, and trying to get to what we call ideal implementation scenario, in which we will be able to get to trying to address the goals of the Ending the HIV Epidemic. And again, this was getting 90% of the population targeted, tested, 95% of them in antiretroviral therapy, and getting at least HIV prevention to 50% of those at risk. So this is a summary of the things we looked at and that made sense. Again, we looked at a lot of interventions, but this is what makes sense. And you can see them divided here in protect, diagnose, and treat. And you can see the different interventions from syringe services program to medication, substitution drugs like buprenorphine or methadone, to care coordination or case management. And you can see at anything that is green are things that we suggested should be expanded. Anything in yellow is things you don't need to expand. You need to continue doing it the way you're doing it. And you can see where we found each one of them making an impact. And similar, if you remove the cost of PrEP, if you were able to get PrEP for free, then that will change a little bit, but it wouldn't change really that much. I mean, you can see that the major difference is in a few cities where you can actually, you can then get PrEP to everybody, basically. So what would happen if you did this implementation, this rapidly scale up of implementation? Well, if you did that, you would probably be able to approach the Ending the HIV Epidemic targets for Atlanta, Baltimore, and Miami. And LA and New York and Seattle will be very close to reaching those targets as well, because they're in the right track already. And you can see in Atlanta, I'll give you the example of Atlanta. If you do the status quo, is this line up here. If you scale up a little bit, this is where you get. But if you do an ideal implementation, this is where you get. And you can see for each one of the cities what those curves look like. And again, New York, for example, or Seattle, their current scale up together with an ideal scale up are pretty close to each other. And what is the cost of doing this? Well, the cost of doing this, the estimated cost by 2030 would be $4.45 billion at present value. And for Atlanta alone, you'll need about $941 million to do this. And a lot of the investment will be front-loaded and would peak with an annual expenditure about $671 million in 2024. And then, and basically, the bottom line is implementing the strategies for our focal cities would require 2.3 times the proposed US national budget allot in 2020 for ending the HIV epidemic for the entire country. So just simply it's an issue of getting additional resources. And again, you can see here how we looked at dividing the money. A lot of the money would be for antiretroviral therapy, for PrEP, and you can see for each one of those cities for implementation, for medication what be resorted for Medicaid and Medicare, medical care, this amount. And again, it varies from city to city depending on where you are. So in some cities you need to put a lot of money into PrEP. In other cities like New York, they're already putting money into PrEP. You don't need to do that. Same with Seattle. So each city has a different mixture of interventions and where do you spend the money in order to get where you need to get. And again, this is the annual estimated annual incremental cost of implementing the optimal strategies. And you can see, again, a lot of money initially, but then it starts going down because you already are where you need to be, and actually the cost starts significantly decreasing over time. So, our conclusion is that if you we continue as a nation doing what we're doing, we will only decrease modestly the new HIV diagnosis, at least in our selected cities, by 7 and 9% over 5 and 10 years. But if you take evidence-based interventions and you scale them up, you can actually be able to do a significant impact. But this would require bridging the implementation gap. I mean, how do you do coordinated delivery? How do you really work within specific context to try to get to where you need to get? And so our conclusions is that the ending the HIV epidemic goals are not attainable at this point without really large reductions in new infections among Blacks and Hispanic MSMs in particular. An ideal implementation, the incidence in 2030 among Black and Hispanic MSMs could be reduced by 78% and 84% respectively, nearly eliminating the disparities in white MSMs. But again, this would require, scaling up of implementation and significant investment in order to reach this. And again, we only really consider in this study delivering interventions that directly impact HIV outcomes. People with HIV, as we discussed previously, are frequently living in poverty with unstable housing, and all those things. Social determinants of health are not being addressed and are not being counted into the cost that we took into consideration. So you still need to think about what can we do to address those social determinants of health that are really driving a lot of the poor outcomes that we're seeing. And in addition, we will need interventions that will help reduce stigma, improve health literacy, address workforce shortages and capacity constraints in healthcare delivery, and reduce all other social and structural barriers to healthcare access. So, my final conclusion is that, while the ending of the HIV epidemic is a nice initiative and it has some lofty goals, I think currently doing what we're doing and continue doing what we're doing, they're simply not attainable. And we will dramatically need to do significant changes and significant investment in order to be able to achieve the ending the HIV epidemic goals. And I want to thank the people that have worked with me throughout the years, and especially in this initiative, and particularly here at Emory, Wendy Armstrong, Jonathan Colasanti, Jeff Lennox, Amita Kaloki, Sophia Hassan, and Rupali Doshi, who now is at GW, and colleagues that have worked with me throughout the United States, in particular, Bohan Dosick, Lisa Mitch, Ed Gardner, Rich Rothenberg, Mike Mugavero, Mopli Doss, and Tom Giordana. And with that, I'll end and happy to answer any questions.
Thank you so much. That was wonderful. I'm going to sort of run through some of the chat questions, and I may ask people to summarize if I don't get these straight. But Nettie Aldis asked about self-testing and the sort of general requirement to switch to 4th generation and sort of how that may impact the utility of home testing.
Yeah, it was kind of hi, this is Nettie. Thank you. It was a great talk. I really enjoyed it. Basically, I was thinking about COVID and the idea of sort of how we sometimes make the perfect the enemy of the good. And so, forcing folks to PCR test when if they can repeated antigen test, you're going to get your diagnosis. And so we've had that shift with COVID. I think for HIV, our testing programs are being pushed to do 4th generation. So it's a blood draw. So you've now lost that benefit of making life easier for people to to do, quick tests in the community, or even push towards, doing home tests or things like that. So that was my question, was sort of, are we making the perfect the enemy of the good by sort of trying to constantly move towards a more sensitive test when we could be doing more slightly less sensitive more frequently?
Oh, I couldn't agree with you more. I think that's exactly what's happening, right? And I think, again, you think about some of the recommendations on PrEP now with long-acting agents saying you got to, do monitoring with viral load and other things. Simply, you're making things more complicated instead of more simple. So I think at some point in time, we need to figure out what do we need to do. There's some populations that we need to reach who will need home testing. We need to figure out how do we get people be able to get, something similar to the COVID testing that you can get at a drugstore, but for HIV at an affordable price, and get them into community so people can test themselves and test themselves frequently. I think we will make a big difference by actually making HIV testing available and accessible to people, as opposed to saying you have to come to a clinic where we do a blood draw, this, that, and the other, right?
Agreed.
But good implementation science studies for us to do.
Yeah. And Aaron Wilcott, how does telehealth affect retention and viral load suppression? Does this have any effect on reducing disparities?
It's a really good question. I've not seen a lot of data on it, and I think it's a really good thing to ask ourselves. I think, we rapidly have pivoted to telehealth, and I think it's a good opportunity to see if we're seeing better retention. My anecdotal experience is that, for those that telehealth works, yes, it's doing really well. But again, we have a significant population of patients for whom telehealth doesn't work. But I'm excited about telehealth. The population that I see it work the best are young individuals who don't want to come to care. And maybe we can make a difference in their viral suppression in young populations, which again are some of the hardest ones to keep virally suppressed.
And then from me, how much of the suboptimal local and national measured ending the epidemic targets do you think are related to suboptimal surveillance data? Poorly captured data resulting from poor reporting, data access across jurisdictions, migration, death, etc. And then Sanjay tacked on to that, what is being done to improve these data collection and surveillance systems?
No, I think that we have a huge problem with data in our country. I mean, people don't realize it, but we have a huge problem with data in which many health departments are still submitting their data via fax. I mean, it's unbelievable. In this day and age, many places are still submitting their data via fax. You go to some places and they have stacks of paper that they need to submit, and they all of a sudden produce data dumps, and that's why the best CDC can give us right now in 2022 is this data from a picture of what the epidemic was in 2019. So I do think that our data systems need to be modernized, and I know that Rochelle Walensky has that as one of her. I mean, she's a data person, and she loves data, and I think she sees that as one of her priorities for CDC is to improve data systems. But it's going to be, it's really. I was talking to her about this, for example. Again, going to COVID, the data system that looks at COVID diagnosis does not link to any data system of who's vaccinated, and does not link to any data system of, so these are all unlinked systems, no data systems for some. And how are you able to do? That's why people like, Qatar and Israel can do the kind of studies they do and publish the kind of data they do, but CDC can't because they don't have the data. So I think we as a nation, I think in public health, not exclusive of HIV, have a huge problem with really bad data.
Yeah, I absolutely agree. I mean, I'm a firm believer that our rate of viral suppression would improve if we just cleaned up our data, or could clean up our data. But there's so much missing, and migration and death, and anyway.
Well, that's a little bit the study that Jonathan did. What Jonathan did here in our clinic, he said, let's look at this cohort of patients that's following over 3 years. And for those that we had lost, at least in Georgia, maybe they went to another state, but at least those that were still in Georgia, he was able to locate through working with the health department, okay, this person is virally suppressed, he's in another clinic. They wouldn't tell him which clinic, but at least he knew this person was virally suppressed, or this person has died, or this person, whatever. And but it had to do a lot of working with the state to get that information. There was no simple way of doing it. Yeah.
Needs to be simpler. All right. And then Nettie again, in your model of the estimated cost for ending the epidemic per region, art is a big part of the cost, but does that factor in insurance coverage? Those with insurance, their art cost is shifted over to the insurer, so doesn't contribute to the, quote, additional ending the epidemic money needed to achieve the goal.
Yeah, no, actually, we did take that into consideration. This is just money that needs to be done for those that don't have coverage, don't have insurance. It does included money for ADAP, for example, and for other programs that pay for public antiretroviral therapy.
Wow, still a big cost. Okay. And then Darcy.
I think part of the big cost is that we pay a lot of money for antiretrovirals.
Yeah. And just maybe going back then, I know you commented on it during your talk, but what's your personal opinion on how big of an impact, if any, long-acting ARTs may have on this, on the ending the epidemic? And, you know, you talked about it in terms of the patient population that had 95% retention and how likely that patient population is to accept long-acting ARTs.
You know, I'm hopeful that it will help with some patients. I don't think it, I mean, again, it's going to be contributing a little bit more into where we need to be. I don't think it's going to be the what solves all our problems, but I do think that it's going to start making a difference. And in that sense, I think it's actually important that we have long-acting agents because it will make a difference.
Yeah. At
least for some individuals. I have at least a few that are now virally suppressed and who had never been virally suppressed as a result of being an anti on long-acting agents.
Great. And Darcy, we just submitted a national study on telehealth in people with HIV during COVID, and interestingly found that older patients engaged more with telehealth than younger patients and women. And point of care, POC, had lower rates of
people of color. Yeah.
People of color. Sorry, I was like, point of care. That's whatever world I deal in. People of color had lower rates of telehealth use. Agree that it's useful in those in whom it works, but not one size fits all. Do you want to comment any further?
That's really interesting, Darcy. I think it's great that you did that study. You know, it's fascinating. At least in the patients that we have here, the younger people are more engaged in telehealth. The older patients, many of them either don't have a cell phone or don't have a computer. They do phone visits, but not necessarily telehealth visits. And again, the other issue that I think impacts the ability to do telehealth, at least in poor populations, is that the cost, the minutes cost, and that increases, and they may not want to engage in telehealth simply because they have fixed cell phone programs plans with limited number of minutes, right? And they don't want to use their minutes to pay for their doctor's visit.
All right. Any other questions from anyone? I encourage people to glance at the chat. Liz Johnson left a link to people who might be interested in learning more about our CFAR Ending the Epidemic Scientific Working Group. There's a link there and a time. We meet every month, and we would welcome you joining our meetings, learning more about ending the epidemic regionally and how you could contribute and participate in our scientific efforts. And if there are no further questions, I will thank you, everybody. Thanks, Carlos. This was wonderful. We really appreciate your time.
Thanks for the invitation, Susan. It was a pleasure to be with you guys. Sorry not to be in person. Would have been fun to be in person.
Oh yeah, absolutely. Hopefully someday soon.
Exactly. Take care.
Thank you. Thanks so much.
Bye.
Bye-bye.